Thanks. For those of you who I don't know, my name is Brian Leroux. I'm the director of the Data Coordinating Center for Precedent, and I'm going to give you some details on what's been going on in the past year. So we've had a very productive year. Tim has mentioned some of the papers. Here's the ONJ study paper that's just coming out in Journal of Dental Research and a couple of other studies. There's this one in Journal of American Dental Association describes descriptive characteristics of the network, and one on tooth wear and community dentistry. So it's been a very productive year. We now have, as Tim said, completed 7 studies, so that's quite an accomplishment, I think, in a 6-year period. The most recent one is the study 17, which was a survey on special needs patients, which you may have participated in recently. So the studies have all been quite successful, reaching or exceeding or at least getting very close to their enrollment goals and leading to several publications. However, we still have a lot of work to do over the next year. We have 7, actually 8, if you count the one retention study that I mentioned on the next slide. 7 studies still ongoing. So a lot of work to do. In particular, there are 2 of them, hypersensitivity prevalence study and a remineralization study, which are new since last year and are still enrolling patients. The others have finished at least the enrollment phase of the study and are ready for follow-up. Again, enrollment is quite good. We're getting close to or meeting our targets in most studies. And for study 8 and 15, we expect to get there. A couple of notable exceptions: the pulp capping trial and the temporary anchorage device trial had to be stopped early before reaching the enrollment targets. So this is the 8th ongoing study now. When I made up these slides, it was still up and coming. It's surveys up and being pilot tested, and you will, for the orthodontists in the group, you'll be getting this survey in your email boxes soon. And it's going to follow up with a survey of patients in terms of their retainer wear. So just give you some summary of our survey studies. We've had 4 of the completed studies that are surveys. Hypersensitivity, treatment of hypersensitivity that was done a few years ago, the PERG, or Practice Impact Research Group study, which is leading to some very interesting findings in terms of how dentists approach treatment of certain conditions, similar to the presentation from DPBRN that we heard earlier. So there are more results like that, so that's being written up. And I also want to mention that we are going to be re-administering the PERG survey probably late summer, early fall this year. So please look out for that. And we're going to be looking at changes in attitudes or practice behaviors, information-seeking behaviors, and so on as a result of your participation in Precedent. So it's really critical, especially if you participated in the first round of PERG, that you respond to the follow-up survey. Okay, then we also have a temporomandibular joint disorder survey and the special needs survey. So after the first survey, we fine-tuned our procedures, and since then we've met our goal of getting at least 80% response rate in all the surveys. So I think we should all feel good about that we've done a good job, and you've done your part by responding. So that's really important to make sure you give valid results. And in terms of the clinical studies, these are the patient numbers for the clinical studies. And as you can see, it's almost 7,000. By the time we're finished, we will have enrolled over 7,000 patients into our clinical studies. So a huge accomplishment. The ones in blue are the studies for which there's long-term follow-up. So caries risk, cracked teeth, pulp cap, third molars, temporary anchorage devices, and remineralization. So those numbers in blue, which represent over half of the about 7,000 patients, these now have to be followed. Well, you're already following them, but what happens over the next year in terms of follow-up of those 3,000 patients is absolutely critical to the success of our studies. So I'm going to be talking quite a bit about that. Okay, so what's coming up? So follow-up, that's the number one priority for all of us for the next year. All those patients, we have to get as many of them as we can back into our offices and complete the study follow-up data. If we don't do that, it doesn't matter that we enrolled 2,000 patients in the carries risk study. If we only get half of them coming back, that's 1,000 patients. It sounds great, but it's going to be a biased sample. So the ones who are easier to bring back and are more likely to come back are quite different than the ones who you don't see that often. I'm sure you all experience that. Certain kinds of patients come frequently and some don't. So we don't just want to get the ones who are coming to see you all the time. We need to get those who don't necessarily visit your office so frequently. Okay. The other thing that's worth mentioning is that these follow-ups are all designed around usual follow-up practices in your office. So we're not really asking you to bring a patient in just to complete a study visit. We'll be sending you reminders and so on to let you know certain patients haven't been seen for X number of months since they enrolled in the study. But that's not to say, we're asking you to create a visit just for the purposes of the study. It's all meant to be part of your routine office practice. And we are just counting on the recall schedule that you have already been using. Other priority, and I'm going to come back to follow-up because that's so important. I want to have a discussion with you about that, some of the difficulties and potential solutions. So we're also completing work on lots of papers. The 11 posters you see outside that are going to be presented at IADR hopefully will all be written up as manuscripts soon. It's really critical that you are entering your data in a timely fashion so that when we pull the data to write up the final results for the paper, that it's as complete and clean as possible. So you might be hearing from your coordinator, or I'm sure you already are, hearing from your coordinator about getting data entered and cleaned. And then we're also going to be very busy on writing the main results papers from all of these longitudinal studies. So the main results are going to be based on the follow-up data that we get. So all the studies, all the posters on Carey's risk study are all about the baseline data. The real purpose of that study is to see what happens within the 2-year period after baseline, which patients get new caries and which ones don't, and is that related to their salivary characteristics and other things. So those papers, our goal is to have them all completed by March 31st, 2012. So it's just about a year from now. So we're going to come up with very careful timelines and milestones and plans for making sure those papers get done. And again, it's going to be really critical that you all get your follow-up data. First of all, that you get the patients in, you complete the exam, and also that you enter the data. So it's going to be a real crunch in January, February, March of next year. So we're all going to be really working under a lot of severe time constraints. And so anything you can do to get your data entered in as quickly as possible will help us with processing it and analyzing it. We're going to start writing the manuscripts throughout the year. We're not going to wait for the data to come in. We're going to start writing as much of the paper as possible, and we encourage all of you to be involved in that. As Tim mentioned, if there's a study you're interested in, contact the PI and just let them know that you'd like to help with writing a paper. So I want to talk a little bit more about follow-up, and in particular show you this. which you should all recognize. This is the newsletter that was sent out in the fall, and it contained these tips for doing follow-up visits for the studies. So if you don't recognize this, let me know. I'll make sure you get another copy. And the other thing is that it's not just for you, but also for the staff. So for those staff who are here, I hope you've seen this. And for you dentists, please remember to share this with your staff. Achieving these follow-up visits is going to involve, a careful coordination between the dentist and the staff members to make sure visits get scheduled, extra time in some cases gets added to a visit to complete the follow-up and so on. Okay. So in particular for the caries risk study, for those of you who participated, you'll remember doing this. Actually, for the dentist, you didn't do this part, the salivary testing. It was done by a staff member. Here, the main message we want to get across is, besides got to get these patients back in and see what's happened to them, but that there are two parts to it. There's actually an in the office clinical exam and information about caries to be recorded from that. Then there's also the chart review, where you look through the chart for the past 2 years and see, or at least time since the patient was enrolled, and see what new caries are recorded there. Okay? But I know it's very tempting, but it's not good enough to skip the exam or don't record that and just base it all on the chart review. So we're finding some people are doing that. So we want to remind you that both these components have to be completed. And please don't wait till the end for questions. If you have any questions about any of these studies as we go through them, please let me know. Yeah?
Regarding the completion of the studies, what if a patient is year and a half into the study and is planning to go, and
right.
contact you guys and see if we can complete the study, or how does it work?
Yeah, great question. The question was, what if a patient is a year and a half from enrollment and is about to move, so you're never going to see them again? What should we do? And we definitely would like to get a year and a half worth of information on them rather than nothing. And so our preference would be that the final exam be done at that time. So if you have any questions about that, just contact your coordinator, and they can advise you on that. Hopefully that the patient has been seen every 6 months and you already have a lot of data on them already, but there might be some, that might be the only piece of data you get since enrollment, and that would be very important to capture that while you can. Other questions about study 2? Okay, so study 5, the cracked teeth study. The participants in that, you should be familiar with this form for recording cracks on teeth. And there's a lot of tips and hints in that newsletter on study 5. I'm not going to go through all of them, but just to focus on this one key point down here, which is basically that this follow-up exam for these cracked teeth takes quite a bit of time. And of course, a lot of our studies take quite a bit of time. We try to build in compensation for you and your staff members so that it's not extra unpaid time. It should all be compensated. But the point is, with this one, it's an extra 10 or 15 minutes of the dentist time. And it's very hard to just add that on to a patient visit when you're not expecting it. So it's creating some challenges. And the only real solution we've come up with is that you just have to add that extra 10, 15 minutes onto this schedule. And again, the budget is set up so that you'd be compensated for that extra time. It sounds a lot easier than it actually is to do, because you have to be aware when making an appointment, this is a patient in study 5 and so on. Yeah? Oh, thank you. Okay, yeah. Yeah, if you haven't read this newsletter and memorized all the contents already, it's in tab 5. So now you don't have to let me know and embarrass yourself that you threw out your copy and need another one. Thanks, Lauralee. Okay, so any questions about study 5 follow-up? How's it going? Are many people having this problem? Very subjective, yeah.
We have to see whether the severity of crack has increased.
Yeah.
So the level of subjectivity is
Okay, so level of subjectivity in assessing whether a crack has progressed or not, yeah. Anything else? Okay. So for the pulp capping clinical trial, a key point I want to emphasize here is that not only do you have to get these patients back, that's actually the part that we're not concerned about so much with this study, because these are people who've had a pulp cap and you've generally been getting them back in for 1 month, 6 month follow-up. Well, you've been getting at least telephone response. There is some question about whether the patients will be seen, and I think some offices are experiencing a lot of success in getting the patients back. Others maybe not so much, and so that's really critical because this is a randomized trial. We're testing two treatment materials. It's really critical that we find out what happens to all these patients who are enrolled in the trial. And not only that, but maybe the hardest part will be that we need a periapical X-ray. And roughly around 24 months, but anytime from 18 months or later. Okay, so it was interesting that in the presentation of the PEARL study, in their endodontic study, they found that half or more than half of the failures were actually only detected on the periapical. And so if that's true for our pulp capping trial, then it makes it all that much more important. If half of the failures are only going to be discovered there, it's really critical that we get those x-rays and get to see those failures. Yeah, so I think that's, any comments on pulp capping trial? So we're actually somewhat disappointed and excited about this. We didn't reach our lofty goal of 640 patients, but we got a little more than halfway there, and we think this is going to be the best study on treatment materials for pulp capping that will have been published. So really excited to see the results on this one, which we won't get to see until the very end. Given that it's clinical trial, we won't be able to report preliminary results. You won't see a poster with preliminary results on MTA versus calcium hydroxide. We'll only get to see results at the very end. Okay, and there's some more tips on the study 6. You can look at those in your handout. The third molar study, I thought this was a particularly pretty picture from the third molar study. This illustrates the final outcome for the third molar study, which is a clinical exam to look at the health of the teeth, the second molar in particular, so the attachment level. So in this one, it's been kind of interesting. We've had some difficulty, we've told you about this already last year, in getting these kids, mostly kids, 16 to 22, to actually respond to our 8-month surveys. So we've only been getting about 50%. And those of you who are in this study know that we've been really been working hard at that. We've been sending you lists of patients who haven't responded to our emails, and your staff have been calling the patients and asking if their email needs to be updated or just to remind them to respond. But even with all that, we're still only getting about, at the 8 and 16 month, about 50% or a little less than 50%. So we're going to keep working on that and hope we get that up. But again, the main purpose of this trial is to look at the clinical outcomes at the end, and so we're going to really focus on making sure we get a high proportion of the patients back for the clinical exam. So you'll be hearing about that. We'll be sending you frequent reminders about patients that are due or overdue for their follow-up visit. Any questions on third molars? Okay. And then the last one I want to mention is the Remineralization Trial that's being done in the orthodontic offices. And for the general dentist, don't get too excited. The purpose of the study is not to convert white spots into cavities. It's to reverse these. This one's going pretty well. The follow-up is short-term. It's only about 8 weeks. And so we don't really anticipate a major problem with follow-up, unlike with the other ones where the follow-up is up to 2 years. It's much more challenging. We think we're going to do fine on this. But for this one as well, it's a randomized trial, and getting all the patients back is really important. Okay, and so if there are no other questions, that's the updates. If you have any questions about just general updates or particular about the follow-up procedures or so on, we can talk about those now. Don.
Brian, you've emphasized the importance of follow-up, and I think that's extremely important. What are the implications? That's something we're wrestling with at NIDCR, loss to follow-up.
Yeah.
What are the implications when you do an analysis of data, and you have a lot of that?
Okay, thank you. Yeah, thanks for that question. So you see a lot of studies reported this way. You know, a longitudinal study where only half the patients were seen at the end. And people they get published, maybe not in a good journal, but in a not so good journal. And I think it's not all that well recognized or understood just how big of a problem that is. People tend to focus on whether you got enough patients back. You know, like in our Carey study, if we get half of them back, that's almost 1,000 patients, and people will say, wow, that's great. The problem is, which half did you get back? They're very different than the half that didn't come back. And so everything about all your results becomes completely questionable as to its validity. Anything you say about association or prediction of caries based on salivary characteristics, it all could just be completely spurious and just due to the fact that you have this biased sample. So it's really, really critical. And 80% is kind of a minimum threshold that a lot of statisticians use. 90 is much better, of course, but 100 is never possible. But that's the kind of range that we'd like to get in. That's why we aim for 80% in our survey responses, and similarly for our longitudinal studies. We'll want to make sure that we get some follow-up data on at least 80% and hopefully more like 90% of the patients. Thanks, Don.
Thanks, Brian. And just one of the things that we have discussed with the national PBRN is having all patients who are registered in studies nationally registered as well, so that they could be followed up by professional entities should they leave your practice. So that way we could somehow attenuate and reduce some of this loss to follow-up, because I know that it's a real burden on your practices when you have to try to call to get somebody in who maybe has left the area and so forth. It's almost impossible. So we're looking at a system for doing that as well, to reduce the loss to follow-up issues.
That's excellent. Yeah. Anyone else have any questions or comments? I think we have a little bit of time, so.
So obviously everybody here is doing a good job on the follow-up.
They must be all doing such good jobs, they don't need to ask. Of course, the ones who come to the meeting are not the ones that are having the problems, right?
Yeah, so we're preaching to the choir again.
Yeah. Okay.
Okay.
Well, thank you all for doing such a good job on the studies. We're really impressed with all the work that you're all doing. Okay.